very, very high, and this was among the advanced HIV disease. Literally meaning if this is not given attention, then probably would see those people actually die because of crypto. Then with esophageal candidiasis at 8%, disseminated histoplasmosis, which is ranging between 1.2 to 1.3. Then chronic aspergillosis, currently most of the studies reported between 6.5 actually to 8.8 in some other study. Then with candidemia, which is really invasive and which usually kills patients, it is standing at five people per 1,000 individuals. Oh, the slides are really disappointing.
Okay, thank you so much. Members, you can be registering in the attendance link that you are sharing, and for professionals that would need these CPD points, kindly put the details in those links so that we can have them uploaded on respective council portal. Thank you. You can carry on, Doctor.
Okay, I don't know why these slides are stopping moving, but let's continue. So as I was saying, that is possibly where we are standing. Then when it comes to non-serious fungal infections, so far oropharyngeal candidiasis is standing between 7.6 as per the study of this year, up to 52.3%, which is slightly high. So that is basically how the country is standing in terms of fungal infections as per the few studies that we were able to retrieve. Then when it comes to antifungal resistance, especially where we are giving a keen ear on fluconazole, it is showing that fluconazole resistance is still being reported and is slightly high as most of studies reported. So among the patients with VVC, which is vulvovaginal candidiasis, in a study done in Eastern Uganda, it shows that out of 126 isolates, 46, which are around 36%, these isolates were resistant to fluconazole. Yet is our first line treatment. Laboratory diagnosis is not commonly done. These are the drugs they are giving patients, but however, we have seen resistance. Then when it comes to crypto, one of the studies that was looking at Cryptococcus neoformans and its fungal resistance, out of the 98 isolates, again 4 of them were resistant to fluconazole, which is really time bomb. Then other studies that one of the studies that we conducted of recent, again we had around 35 isolates, and 5 of them were resistant to fluconazole, making a percentage of 20%. Then another study that was done by Mukasa and colleagues in Western Uganda, again, surprisingly, most of the non-albicans candida were resistant to fluconazole, which is a drug of choice, up to 100% of the Girabrata, the Cruzei, and C for matter were resistant to this drug. So that is how we are standing in the country. Then if I'm to pose a question to my fellow laboratories, what do we need to do? That has been a question for mycology. That is a call for all the stakeholders. So I'm going to pass through the lab diagnosis of fungal infections. Besides looking at the entire Africa, what has been done, the basis, then how do we move? how do we give capacity to individuals who are participating in lab diagnosis? So why do we need to get concerned about lab diagnosis? One, we need to confirm the clinical suspicion to establish fungal cause of a disease. Literally meaning if these patients are put on treatment without diagnosis, without laboratory diagnosis, then the suspicion is not confirmed. And you gave a good example of Lira, where they were suspecting a bacterial infection. Kumbe it was fungal infection. So that is the ultimate goal, and that's what we want to see happen. Then, because that will help one in choosing appropriate therapeutic agent, a very appropriate antifungal agent. Once lab diagnosis is done, monitoring the cause of the disease and confirming if the cure has been successful. That is the ultimate goal for having lab diagnosis done prior to treatment. Yes, we are talking of lab diagnosis, but one of the key challenges or one of the requirements is that the lab diagnosis of fungal infection, especially in Africa where we are living, it involves a combination of clinical assessment. If the clinical assessment is not done appropriately, then the clinician will not make a request. So literally meaning the clinician must really be informed of what is happening, must be knowledgeable. Then once a requisition is done, then the laboratory techniques should be conducted. However, all these require availability of resources because some requisitions are done, they are sent to the lab, the clinician is more knowledgeable, knows what to do. By reaching the lab again, the lab has no capacity to conduct these fungal diagnosis, literally because of limited resources. And given this diverse range of fungal pathogens and varying level of healthcare infrastructure across Africa, the approach to diagnosis can differ significantly. You can see this, that probably what's happening right now in Uganda, the focus is given at reference laboratories and regional referral laboratories, where we can have microbiology lab. But down in lower facilities, because of resources, probably lab diagnosis is rarely done. So there is a kind of combination of all these aspects of having resources, having information by clinician, then assessing the level of information of etiology. So what we need, first of all, like the procedure. It's important that if the clinician is really request for NSS, it's important that the type of assessment is decided depending on the suspected infection. So if long infection is suspected, then it will mean the long sample will be collected and definitely affect the diagnosis. So assessment may ignore that. Depending on the size of the infection and depending on the suspect. If someone is probably suffering from pneumoconiosis, then the lab is expected to do that on the lab, that's and that's very key to know of where the sample is collected, what are the infection that is suspected, also that we guide in what type of sample be collected, and then ultimately the same sample should be transported very well, because transport is vital to maintain viability of the fungi of agriculture. So packaging as also these fungi, they have power and they can be transported by radiation is power. So packaging is very key, because if the packaging was not done well, then definitely that may affect the transport, may affect the health of the product, and that's why at even which lab it requires that may really have a lot of powers that affect humans. some samples which allows we are going to look at a quite number of techniques. However, we have a approach where my microscope is the first one is done and a basic. Being around microscope usually basic to give out the morphology. And after that, I can done fungal culture, as the cluster, and so this culture is isolated the fungal culture, then support for identification. Then serological tests are also done and antibody response. They neutralize as discussed. So what are the key diagnostics? Minimum as there are some key the high priority pathogen. What should we do? For instance, aspergillosis, CT scan could be done. And what is serological tests could be done. Biopsy could be done. Culture could be done. Pathology could be done. For those having high priority pathogens. Then my microscope is very key for going for high technologies, technologies, all of this could be done with minimum resources that is have high now so there is what for semi-fungal diagnosis because we say this fungal they may not kill, but when it causes intensive it's what referring to because it has been disseminated body. So it is important to understand the power and for any patient with clinical symptoms that are not responding and antibiotic treatment. Someone was responding. What you have to do with the kind of clinician is now a diagnosis. So the diagnosis should be provided for the hypothesis for both of these symptoms. Otherwise, one can go around with the fungal infection, can go around with the viral infection. Otherwise, people compound with the bad responding, and that's what we are seeing a lot of Benson and Muni. So when the differential diagnosis is done, then we have another differential diagnosis. Bacterial infection should be ruled out, and there is no bacterial infection. Then the fungal infection should be suspected in this framework. So after evaluating this, then it's important that now, besides this suspected fungal infection, it's also important to look at three parameters: that is the host factors, the human manifestation, and my evidence. Because as with fungal infections, usually affects immunocompromised individuals, the individuals own chemotherapy, all those factors should be ruled out before going for any of my evidence in the so that is very important and at that stage. Then after those factors have been ruled out, then I think some probably other diseases compromised patients there are common manifestations as this is infection. That could be done depending on the type of sample. This concentration of progenitor media where changes in colors depending on the type of pathogen, and microscopy done is a biopsy, then pathology staining can be done alone. Then after that, histological surveillance here on the type of infection that is suspected. Histological tests will be done, and there are histological methodologies that are now available in the market. However, now we are also managing fungal pathogens that are hard to prepare from others. We are now a method can be used by machine can be used by between different pathogens, especially the Candida species. All that can be done.
Kind of wind up. I think time is not our best friend now. You can wind up and see how we can.
Okay. Thank you. Then in advanced diagnosis, a PCR can be done, sequencing can be done. All that supports throughout fungal infection. So briefly about treatment, I felt we should chip in. There are quite a number of 4 classes of antifungals that are available in the market. Some of them, they target they are topical antifungals for superficial infections. Then there are those that are oral antifungals, again, that are used in extensive in systematic infection, and intravenous antifungals in case there is disseminated infection. Antifungals like amphotericin B can be used for this, and combination of therapy in case there are resistance that are suspected. So the management strategy, usually it's important to keep the affected area clean, inform the patient about the risk factors, and in case someone is prone to this or compromised, prophylactic antifungals can be used. So briefly, the antifungal drugs, of course, they act differently, but the azoles you're seeing here, these azoles, they bind to and inhibit a gostro11 enzyme, and subsequent, they will inhibit agostro production, and this will affect the cell wall. Then with the chinocandins at muscle, they also bind and inhibit beta-glucan synthetase, which disrupt the cell wall, and once the cell wall is disrupted, then it won't function appropriately. So as lab diagnostics, or as lab profession, what are the many challenges that we are facing in Africa in terms of lab fungal diagnosis? One of the issues that was said before is low suspicion index, that our clinicians are not suspecting diagnosis. There is limited antifungal drugs because we have seen we have only 4 options at the moment that are in the market, 4 classes. Then cytotoxic, these drugs are very toxic, affecting diagnostics in the country, plus the emerging pathogens. And besides that, as Africans, we have limited to really fund mycology laboratories. Training and expertise is very, very key, where we have limited mycologists in the country. We have limited expertise who can really move fungal diagnostics forward. So there is need to look at that. Diverse fungal flora that is now common with emerging fungal pathogens, co-infections, environment. We are thinking of antibiotic resistance, but now we have antifungals that is coming on board, coupled with antiviral